Good afternoon, participants. Hello.
Hi, we can hear you.
Yes, my name is Anastasia. I am an oncology nurse and at Kenyatta National Hospital, and the patient navigation program manager at KNH. And I am the chair in today's session. I would like to take this opportunity to welcome all of us into today's session, which is a continuing cancer series session. And today we look at prostate cancer. And in our session, we'll have an overview of what prostate cancer is. We'll also look at survivorship issues in prostate cancer. And then we'll have a perspective from one of the survivors. Our panel today, we have Dr. Keegan Kirugo from Kenyatta National Hospital. He's a resident in the urology department. Will be taking us through cancer, prostate cancer to be specific. As he comes in, he'll introduce what he's going to talk about. We also have Ronnie, who is an oncology clinical nurse navigator at the Kenyatta National Hospital, who will be talking about survivorship issues in prostate cancer. And we also have a survivor who will be talking to us about his experience with the prostate cancer. So without taking too much time, I would like us to start. And we will start with our prostate cancer survivor. I don't know if we have Joshua. Joshua, are you on? Nelson, is Joshua with us?
Joshua, yeah.
Okay, thank you. Thank you very much, Joshua, for making time to be with us and even to share with us your experience. And I would like to give you this opportunity to please speak to us. These are healthcare workers mainly. So, and others who have joined us, we thank you and you're welcome. So Joshua, please take over.
Hello everyone, can you hear me? Joshua will be using this one.
Yes, that is Millicent.
Yes, Joshua is using my. Can you hear me?
Thank you, Millicent, even for being able to support us.
Yes.
Yes, Millicent, we can hear you.
Okay. Just endelea.
Good afternoon.
Good afternoon.
Majina yangu naitwa Joshua Ambuzi. Miaka ni 62. So nilianza kusikia mwili wangu ikiuma upande. Saa zingine nilikuwa nasikia kichwa kinauma throughout. Saa zingine nikasikia upande wa sikio huko ikiwa na kidonda hivi. Nikaenda wakatibu kidogo, ikasikia vizuri kidogo. Nilikuwa nasikia mgongo nikikaa inakuwa ni shida, nikisimama inakuwa ni shida. Yani sikuwa naelewa ni nini naendelea. So mimi nilikuwa naendelea tu na kumeza paracetamol, madawa za machungu tu. So saa zingine nilikuwa nasimama nasikia magoti sielewi. Nasikia mabega sielewi. Nikapitia hiyo mambo kwa mwili sana mpaka ikafika mahali nikikula chakula ikawa ni vigumu sana. Chakula nakula kidogo sana. Hata kama ni katosti moja sikuwa namaliza. Hata kaugali kakawekwa kapisi sikuwa namaliza. So ikabidi niende hospitali. Kabla sijaenda hospitali nilipitia changamoto ya magonjwa kwa mwili sana. So sikuwa najua na sikuwa naelewa ni nini naendelea kwa mwili wangu. So nilikuwa tu nakula madawa kidogo, naambiwa kula hii ya kienyeji, yenyewe nikikula nasikia niko sawa, miezi 3 miezi 4 hivyo tu. So ilifika mahali ikafunga mpaka hata kukula ikawa ni shida. Lakini nilipoenda hospitali ya Mata Hospital, wakapima, walipopima wakaniambia uko na cancer ya prostate cancer. So kabla wanyambie washapata vipimo zote, ilikuwa ni vigumu hao kunitamkia, lakini niliwaambia tu nitamkieni sababu mimi ndio mgonjwa na mimi ndio naumia. Hakuna kitu nitafanya ama nilie ama nifanye nini. Nikapembeleza daktari, ndio sababu alikuwa bado ananizungusha. So ndio akanieleza, nikamueleza tu ni hiyo tu, akasema ni hiyo. So akaniambia tutakupa referrals uende Kenyatta. So ndio huko utakuwa ukitibiwa. So nikapewa referrals, nikaenda Kenyatta madaktari wakanichukua, wakapima hata nao wakaona ndio hiyo. Wakapima pia na mifupa, wakaona hiyo kanza imeikula mifupa sana, kila mahali ya mifupa, joints za mwili wangu wote ilikuwa ni hiyo. So nikaanza matibabu. Najua once tu umekutana na daktari wa Kenyatta inakuwa ni vizuri, na sio rahisi, lakini ni vizuri. Shamkutana tu naye, unajua mambo yangu Mungu akipenda itaenda mzuri. So nikaanza matibabu Kenyatta, na nilikuwa nikikula ninatabika, kukojoa ni saa yote tu naenda kukojoa. So ikawa ni mambo hiyo ya kutabika, hiyo kukojoa, hiyo ikawa ni mingi sana kwa mwili. Lakini daktari walipambana na kunibadilishia madawa, na bado ninaenda kemu naenda tu. Na kwanza hapo mbele nilikuwa prostate cancer ilikuwa imeingia, imefika 4. So wakaniambia hiyo 4 hatuwezi choma, tutakuwa tukikupatia tu madawa kemo tu peke yake 6, tutakupatia hizo na utasikia mzuri. So tukaendelea namna hiyo. Changamoto iko, saa zingine pesa iko, saa zingine pesa hakuna, sababu mimi nilikuwa nategemea mke yangu peke yake. Ndugu zangu walikimbia. Sasa nikashangaa hii magonjwa kumbe ni hatari sana. Ndugu zangu wakanikimbia, hakuna mtu alikuwa anakuja karibu na mimi, hakuna mtu alikuwa ananipigia hata simu. Hata marafiki walipopiga simu mara moja mara mbili wakawacha na wakaenda kabisa, hata kupigiwa simu ni ngumu. So ikawa tu mimi na mke wangu tu tunang'ang'ana tu. Sasa tukaweza kuendelea namna hiyo. Nafika mahali saa zingine unasikia mzuri, ukiamka unasikia saa zingine mgongo, saa zingine unasikia magoti, saa zingine miguu zinafura na zinawacha, na tunaendelea tuna matibabu. Daktari anajaribu kubadilisha dawa kila wezavyo. Sasa nimeendelea hivyo. Sasa ikawa inachukua sasa muda ndio anze kusikia kwa uchungu mahali fulani, na tunaendelea hivyo. Saa nyingine unasikia tumbo pale wanadunga hizo nini ya kemo, hiyo shindano hiyo kubwa hiyo. Na siku hizi imepoa, hata vile inaendelea hapo vile unaona unaweza inama, saa hii naweza inama, naweza kuinuka kidogo, hiyo tumbo imepoa kidogo. So unakuta ya kwamba saa zingine unasikia mgongo, saa zingine unasikia kichwa, saa zingine unasikia joints za mikono, huwezi kunyorosha straight na huwezi kufanya nini ama kukunja ama kuchukua kitu. Lakini wakati mwingine kama wakati huu unaweza endelea kufanya kunyorosha mkono, unaweza chukua kitu hilo unataka. Miguu nazo pia saa zingine sasa zimepoa kidogo, naweza vaa kiatu kidogo wakati huu, unatafuta kiatu ambayo ni size kubwa ndio uvae. So mimi nashukuru sana madaktari wa Kenyatta ambao wanaendelea kunitibu, ambao wananipenda na ninawapenda sana, kwa sababu ninasikiza yale yote wanayoniambia. Vyakula pia nilikuwa nakulanga chakula ilikuwa ni vigumu, na saa hii kaniambia kula, ninakula vyakula yote iko za kula, hata nyama kidogo tu, lakini samaki nikule kwa wingi, kuku nikule kwa wingi, mboga nikule kwa wingi sana, maziwa mayai kidogo kidogo. So naendelea tu namna hiyo, na ninaona mwili wangu inaendelea vizuri, iko na afya iko zaidi. Saa hii niko na kilo zaidi ya 100. So saa zingine wanasema upunguze. So niliambia siku ingine sasa mimi niwache kukula ndio nipunguze, akasema kukula ndio ukule, usijaribu kufunga ati kwa sababu ndio upunguze kilo. Hapana, kilo utajaribu bila uwezavyo, kutembea kidogo, na usiende kwa flyover. Tembea karibu, unaweza tembea kama mahali manaweza kuchukua 30 minutes or 40 minutes, uende urudi, alafu siku inaisha hivyo. So nimepitia hiyo changamoto hiyo vile jinsi ilivyo, lakini bado tunakasa mwendo. Safari ni ngumu, lakini bado tunaendelea. Ya kwamba daktari Kenyatta nawashukuru sana, nawapenda sana. Ushamfikia tu hiyo daktari, mambo yake na kuwa sawa, kwa sababu unapoingia kwa daktari si kama zile hospitali zingine, unakaa anaangalia kipimo kinasema namna gani, anakuuliza kipimo kinasema namna hii, na wewe mwenyewe kwa mwili wako unasikia namna gani. Ukimueleza sisikii vile na unasikia vile kipimo anasema, anafurahi. Anasema sasa nitakupunguzia dawa fulani na uachane na hii na uweze kuendelea na hii. Yani ni watu ambao mtu tu waseme mtu mkarimu, yani mtu ule anaelewa, mtu ule anajua ile kitu anafanya, mtu ule anaweza kupembeleza mgonjwa hata kama ajisikii ama mawazo yake iko mbali, anailete karibu. So nawapenda sana hao madaktari wa Kenyatta kwa kazi nzuri ambayo wanafanya. Jambo lingine, changamoto ile tunapitianga ni hali ya kifedha. So unapoenda kutibiwa mpaka uhangaika hapa na pale, uone ya kwamba umepata ile fedha uende kutibiwa. So naona ya kwamba sina mambo mengi ya kuweza kusema, bali mimi namshukuru mke wangu, na ninashukuru ile ambayo tunaiungana pamoja na tunakuwa pamoja, nabadilishana mawazo pamoja. Unaona ya kwamba uko sawa na unaweza tena kusaidia mwingine, unamwambia jipe moyo. Nilipitia hivyo, lakini niko stage hii sasa, hata wewe utafika ile stage nimefika, na uweze kusonga mbele. Sana unaona ya kwamba hata nikikutana na watu mtu hawezi jua unless nimwambie niligonjeka hii. Siwezi jua. Wale walijua ni wale wa kwanza tu, wale walikuwa karibu, lakini mtu mwingine yote nikimwambia anasema hapana, ulipata kazi mzuri, unaendelea vizuri. Kwa hivi sasa nimesimamisha hiyo dawa. So natakana by next week niende kukipimo, nione niko namna gani, waone kama nitaendelea tu na kimo peke yake na mambo ya madawa niwachane nayo. So dawa niliwachana sasa hii kwa miezi 3 sikudi dawa. Asante.
Thank you Joshua. Asante sana Joshua kwa hayo ambayo umetueleza, safari yako na ugonjwa wa prostate cancer. Labda ungeweza tu kutueleza jambo moja tu kabla hatujaenda kwa mwingine. Sijui kama ni mimi sikusikia vizuri, lakini uliweza kuwa diagnosed na ugonjwa wa prostate cancer kama mwaka gani?
Ni last year mwezi wa 7.
Okay.
Ya hiyo sasa ndio kipimo ilitoka ikasema niko nayo, lakini kule mbeleni ilianza kitambo kidogo na sikuwa najua.
Asante.
Sawa.
Joshua, nafikiri utangojea tu kidogo tukimaliza na hawa wengine, labda kuna maswali ama pengine mahali tu watu wangependa uweze kuwaelezea kwa kindani zaidi, tutawaleta baadaye. Saizi tutaleta wengine waweze kuzungumza, kisha tutakuja kwako baadaye uweze kutuelezea kwa kindani zaidi baada ya daktari kuongea. Asante Joshua.
Asante.
Thank you. I think we've heard from Joshua's perspective, his experience with prostate cancer, and he also his experience with the treatment that he's going through. And at this juncture, I would request that we hold on to the questions that we have. We shall have a session where we'll be able to have questions and answers at the end. That is after the presentations from the other two panelists that we have. And at this point, then I would like to invite Dr. Keegan. Dr. Keegan will be taking us through prostate cancer. Will give us an overview of prostate cancer. Welcome, Dr. Keegan.
Thank you. I hope I'm loud and clear.
Yes, we can hear you.
Okay. Asante Joshua kwa kutueleza jinsi we are pia sisi tunajifunza kutoka kwako. So my name is Dr. Keegan. I'm a registrar here at KNH National Hospital. I'm in my 5th year of urology, and I'm tasked with presenting on an overview of prostate cancer. First of all, I must mention prostate cancer is really a wide topic. So I'll try to be to touch on all that pertains to prostate cancer, from what it is to how the principles that we institute. So first of all, the mention of cancer, just like cancer generally has a lot of stigma, and prostate cancer notwithstanding. So what is prostate cancer? Prostate cancer is where you have cells kind of undergoing, they undergo genetic alterations, and they start to proliferate in a way that is uncontrollable. And the new cells being made don't even look like the parent cells, which is the prostate cells, okay? And this should not be confused with another condition, which has a bit of similar epidemiology to prostate cancer, which is a benign prostatic enlargement or hyperplasia. And benign prostatic enlargement is just a normal, let me just say it's a change of the prostate that happens with, usually happens with age. About 60% of those above 60 years, 80% above 80 years in estimate will have this benign prostatic growth. So it's just the cells have a large, and the cells have increased in number, and they are similar to the prostate. They look similar to the prostate cells, but cancer is uncontrollable and they don't look similar. So that's just as a basic, if I could explain at the basic level. What's our epidemiology here that we see of prostate cancer? Prostate cancer tends, when we look at, so the epidemiology of prostate cancer tends to affect increase with age. So age actually is an important risk factor. Of course, gender, it goes without saying, is male. And I must report that there are studies that that were carried out where they went to the mortuary and sampled prostate tissue of the bodies there, and they found that 30%. They found that those who are in the range of 50 years, 50 to 60, 30% of them had prostate cancer. Then they went and looked at those in their 80s, 80 to 90 years. They found that 80% of those in their 80s had prostate cancer. And as you approach 90s to 100 years, almost 100% of them had prostate cancer. But the interesting thing that I must mention is the lifetime risk generated from global studies that we have. The lifetime risk of dying from prostate cancer is 3%. But the lifetime risk of getting prostate cancer is 16%. So that means that prostate cancer is not a death sentence, really. Yeah. And this at least helps to destigmatize prostate cancer. And I'd give examples. Mandela at one point, I remember, had been diagnosed with prostate cancer, Desmond Tutu, and they were able to achieve the best they could in their lifetime. And we know also of a renowned gentleman in US, Ben Carson, who was a neurosurgeon and was also the Minister of Housing during the Trump administration, was diagnosed with prostate cancer at one point, and he was able to achieve, he's been able to achieve a lot. So people in the back here home, we have the governor of Kisumu disclosed publicly that he had been diagnosed with prostate cancer, and he's been able to achieve a lot in the political arena and in the academic arena, being a professor. So still one can go and achieve the best they can be with prostate cancer. Another risk factor is race. The Afro-African, Afro-American and the African race tends to be, compared to the Caucasian race, tends to be significantly affected by prostate cancer, relatively more affected than prostate cancer, with prostate cancer compared to the Caucasian race. Another significant risk factor is family history, because if you have a relative, close relative who had prostate cancer, then the risk increases to up to 2 to 3 times. The risk further increases if you have 2 relatives who had prostate cancer, to up to 5 times. By the time we reach 3, the risk increases to 11 times. And I want to say that we are not limiting here to prostate cancer, even breast cancer, because the genetics, there's a gene called BRCA1 and BRCA2, and especially BRCA2. Once there's a mutation in that gene, the risk increases to 4.5%, So if someone, close family had breast cancer, then that says that there's an increased risk of someone developing prostate cancer. Other risks that have been noted that favor increased risk is obesity. There's also papers that have talked about meat and dairy products, but I'd say it's not really as strong as the 3 risk factors I've mentioned: family history, age, and race. So obesity, meat, dairy products have been shown to have increased risk, but not really as strong. Secondly, there are those that are protective, that is reduced risk, that is vitamin D intakes, societies that have high levels of vitamin D. There's been a debate, does inflammation like prostatitis, infection of the prostate increase, and fruits and vegetables. So the latest we have is that it doesn't have, has not been shown to increase the risk. Fruits and vegetables also have not been shown to really have protective, being protective against prostate cancer, and that's what we have latest. As I say, prostate cancer, let me just mention, prostate cancer is something that really has a lot of funding globally, and there are new studies cropping up every now and then, new ways of treating. And so we have to be updated, and that's the latest of what we have. About testosterone levels, there's a drug we give there's a drug we give for managing benign prostatic enlargement, and that's the drug is called, the class of the drugs are called 5-alpha reductase, that helps reduce the potent form of testosterone. And these patients have been followed up, and they've been seen to have a lower risk of developing prostate cancer. And we have papers that support that. So that's under the hormonal influence, testosterone in particular. So how does someone present with, what are the symptoms associated with prostate cancer? First of all, back to the risk, I want to say that the statistics here of that we have at KNH is we have an average age of 72 years of patients who have been who are being managed for prostate cancer, and that really gives credence that really most of our a good number of our patients are within the elderly males. And I want to say that from our statistics, the youngest who presented was at 48 years. So even as much as we are seeing the risk being increasing from 50 years, there's also a small risk in their late 40s, but in particular, if there is a strong family history of prostate cancer, they tend to present earlier than the average age, than the common ages that we see. So they tend to present earlier. You'll find patients at 45 presenting with prostate cancer, and this is usually in the respect of strong family history. So how does a patient present clinically? So when you look at the anatomy of the prostate, it encircles the urethra, which is the the pipe that drains urine, and the prostate biologically has a function of producing. It contributes to the production of semen. Yeah. So the fact that it encircles the urethra means that proliferation of it might be associated with urinary symptoms, and this they range from frequency where someone has like every time they have to go and pee, urgency where they are feeling the urge to pee or void, and what we call nocturia is waking up at night frequently to go and void. And also other symptoms include a weak stream where it's like urine is being blocked, intermittency, what they say in Kiswahili, mkojo inakatika katika. It's not a smooth stream, a smooth continuous stream. It's like it's inakatika katika. And there's also a feeling of once you've urinated, it's like there's something, there's urine that is remaining, and you have to go back and try to expel, drain the remaining urine. Other symptoms include, and also non-specific symptoms like fatigue, a sensation, fatigue, and appetite changes. Like you see, I liked how Joshua shared, and because his was more non-specific symptoms, because they are what we call specific symptoms, like this urinary system symptoms, you can really narrow down to what it is, but the non-specific, it's really difficult to narrow it down to what is the underlying problem. And then there are also symptoms of complications. When you look at the anatomy of the prostate, there are veins that communicate with the spine, and these veins tend to be valveless, meaning so blood can flow in either direction. So if you have cancer cells of the prostate, then they can spread to the spine, and then someone can come present on a wheelchair because of spinal involvement. And also if it blocks the pathway of urine, because we remember we talked about that it encircles the urethra, then there'll be significant backlog upstream, and the kidneys will be affected, and someone might end up in what we call chronic kidney disease or renal failure, end-stage renal disease, and they have to depend on dialysis. So it's some of the complications: renal failure and spread to the spine. It's a complete area that those are more of symptoms of advanced disease. And also sexual symptoms like erectile dysfunction can manifest in the background of prostate cancer. Moving on. So the prostate can also invade lymph nodes, and there can be pulling of the lymph nodes, which are glands that help excrete wastes. So now, once this has been invaded, this lymph cannot be excreted well, and therefore you find that even the legs start swelling as part of a complication of advanced disease. So now, are there ways of diagnosing this prostate cancer apart from the symptoms? So someone presents with those symptoms. So what next? And this is what we call now, it's also a form of what we call opportunistic screening, where we're using the symptoms as an opportunity now to screen for prostate cancer, as opposed to what is called systematic screening, or some people even talk about mass screening. So if someone presents with these symptoms, we go ahead and do, so the principle is we start with something that is readily available. So we, after sitting down with the patient and noting down the symptoms, whether constitutional, whether they are systemic symptoms related to the urinary system or reproductive system or advanced disease, the next thing now is to do to examine the prostate. So the prostate, it encircles the urethra. That's what we've talked about. And then the posterior aspect of the prostate, like pneuma, is when you stick a finger in the anus, it's a few centimeters above the anus, and you can feel the prostate if it's enlarged. And that informs the basis of us being what we call a digital, digit being the finger rectal examination. So the prostate, if it's benign picture, usually tends to have, the BP tends to be a smooth prostate. Both of them can enlarge, prostate cancer and BP, of course, but the smooth contour of the prostate tends to portends usually to a benign process, but a nodular contour portends to a malignant, cancerous process. Another thing is, what's the consistency? Firm consistency, like usually we tend to relate it to the tip of the nose. When you touch your tip of the nose, it's firm, okay? But when you touch your forehead, it's hard. So that hard is tending towards a malignant process. And that firm surface tends towards a benign process. Okay, so that's how some of the things that we look at. But there are many more things I can talk a whole 1 hour just on DRE, but that's just part of the main things that we tend to tease out. We're teasing out, is it benign process or is it tending towards malignant process? And then there's a blood test called a PSA. So remember, we said that what's the function of this prostate? We said that it helps, it contributes a percentage of the semen, because there are also other glands called seminal vesicles, which are located behind the prostate, which also participate in production of semen, as the name suggests, seminal vesicles. And so prostate, seminal vesicles, there are two organs that contribute to semen, and hence facilitating reproduction. Yeah, because the semen contains sperms. So so in 1970, the gentleman who came up with PSA in 1970 as a tool for prostate cancer screening, and also we also use it for monitoring our treatment for prostate cancer, used this physiology that, yeah, PSA is it's an enzyme produced by the prostate. So PSA is specific to the prostate, okay? And this enzyme helps make the semen less viscous, okay? So it has a cleaving property. It cleaves the bonds within the semen, okay, and makes it less viscous, hence facilitating fertilization in the end. So now, what if you have cancer cells proliferating rapidly? Then it's expected that the PSA levels will be higher. So that's the thinking behind this 1970 landmark investigation for prostate cancer. What's the critical value? The critical value we look at is 4, but that doesn't mean to absolutely to say, one thing that we need to get right is that PSA is specific to prostate gland, but it is not specific to prostate cancer. So that's one thing we need to be clear. There are other things that can raise the PSA level, yeah? So the critical value that normally we use is a value of 4. So above 4 now, it starts being suspicious, but we can give a leeway, like if someone is 70 years, because also, remember also as we age, the prostate also enlarges, okay? So above around 70 to 80 years, we can give a leeway of up to 6, okay, for a normal PSA. We don't have reference ranges for Kenya. What we're using are Western reference ranges, and at least they've been so far, so they've been useful. And so a cutoff of 4 is one thing that we take with the much ado. So if we said that it's not specific to prostate cancer, so other things can elevate this PSA. Number one is an infection of the prostate can elevate the PSA. Someone who has retention, yeah, where urine is blocked, they cannot pass urine, and the bladder now becomes distended. it can also trigger a high PSA. Okay, so and also yeah, those are some of the main things that can trigger PSA. And someone who has a catheter also can trigger, catheter being the pipe that we insert, can be inserted per urethra, in case someone has to measure urine output, or in case someone has a blockage and we need to divert the urine so that we don't prevent complications associated with urine retention, like recurrent infections or even prolonged renal failure. So they insert a pipe called a catheter. And so in a patient who has a catheter also, that can also increase the PSA level. So and that's why we are saying it's not specific to prostate cancer. And prostate cancer itself can also elevate the PSA levels. So it's a very important tool in our overview of prostate cancer. So PSA and also a digital rectal exam, in addition to the symptoms that someone presents with. Another thing to mention is, so what's the role of, is there a role for imaging, like an ultrasound? An ultrasound is of good utility because it has the ability to tell us the prostate size, and also tells us whether the prostate is nodular or not. Okay, so this ultrasound can be done transabdominal, where you place a probe on the lower abdomen, or can be done transrectal, where you place it to the transrectal route. If you want to see the prostate, the transrectal route is usually the best as opposed to the transabdominal route. But a complete ultrasound, what we usually do is a full kidney, ureter, bladder ultrasound and prostate ultrasound, because you want to see, are there also complications upstream? And then hence the favoring of transabdominal ultrasound, because it will tell you from the kidney to the prostate. Yeah. So it can tell us, number one, helps tell us whether the prostate looks suspicious or not. And number two, are there complications associated with the prostate? Like if there is backlog, the urine tends to distend the kidney, so the kidneys appear bigger. In medical terms, we call that hydronephrosis, which is something that makes us even treat this patient with the utmost urgency, because we don't want any complications. Yeah. So what's the gold standard? The gold standard investigation for prostate cancer is having a tissue of prostate and looking at it in a microscope and being able to tell you, yes, these cells do not look like the prostate, and they have they look like they are rapidly dividing, and so this is prostate cancer. So biopsy tells us whether it's prostate cancer or it's a benign process, in case someone presents with symptoms and you do a rectal exam and the prostate is enlarged. And there's a scoring system that we use, which is called the Gleason score. Basically, it looks at the worst pattern and the second worst pattern of the prostate. Just worst pattern is to say that the cells really do not look like the normal prostatic tissue. So the more they appear like they don't look like the normal prostatic tissue, the worse the pattern, because they have a high risk of proliferation, if I just put it at a basic language. And so this score is very important because it enables to tell us, is the patient at a very high risk of advanced disease, what we call high risk, or they are intermediate, katikati, or it's a low risk prostate cancer. So biopsy is the gold standard of diagnosing. How is this biopsy done? We can do it, it's usually done under anesthesia, can be local or GA. So anesthesia, we give anesthesia. You see, the prostate is surrounded by what we call a capsule. And when you go it rectally, it's surrounded by also, there's the rectum. So we tend to look for a plane between the rectum and the prostate and give anesthesia on that plane. Or in some centers, they also do it under general anesthesia. So the plan here is to ensure that the patient is comfortable as we are doing the procedure. That's the goal, okay? So we take a number of tissues. Depending on the prostate size, we might go up to 12 cores, standard cores. And so we take these cores are taken to the, so it can be done either using a finger guided, or you can use an ultrasound, okay? That's the normal, that's usually what we usually do. But other centers, like in the Western countries, they also have what we call MRI-directed biopsy, where they use an MRI to guide where to make a puncture. But still, despite that, we are still able to make a diagnosis regardless of which modality we are doing, whether we are using an MRI, an ultrasound, or finger-guided biopsy. If it's a small prostate, then we tend to use an ultrasound because it can be able to detect for us where does it look, where does it look suspicious, yeah, like a nodule, for example. So is there a role? So that's how we do our biopsies. Anesthesia is very important, and getting a good number of calls sufficient to take to the lab. That is the pathologists are the one who do a good job in reporting for us whether they are prostate cancer cells or not. Is there a role for MRI and CT scan? MRI is very important because there's a MRI limited to the prostate, and that's what we call a multiparametric MRI of the prostate. So it's able to show us if this prostate, does it favor benign or does it favor malignant? And there are scores that are given, which is called the PIRAD score. For those who are in radiography or in the oncological clinical setup, there is what we call PIRADs for breast cancer with mammography. And also here we also have what we call PIRADs being the P being prostate. And there are grades from 1 to 5, 5 being likely malignant, and 1 being benign, and 3 being intermediate. So as you go up the ladder to 5, the likelihood of malignancy increases. So a multiparametric MRI helps us determine earlier that what are we dealing with, and has been shown to have a high specificity and sensitivity. So it helps, like it acts like a triage, is who needs biopsy, who doesn't need biopsy. So there's also what we call MRI, like a whole body MRI. This enables us to tell us, is the prostate, has it spread to other organs? Okay, yeah. So we've detected there's cancer. So what's the next step? The next step is determining, are we dealing with an advanced metastatic disease which has spread, or we are dealing with a disease that is within the prostate gland? And that's why the utility of an MRI, CT scan, and a bone scan come in, right? Those are the diagnostic tools that we use for prostate cancer. There's also newer tools that have been introduced in Kenya. I know Aga Khan and KU have what we call a PSMA PET scan that also helps tell, are there cancerous tissue in other tissues other than cancer cells in other tissues other than the prostate. Yeah. So those are part of the tools that we use. So till now, the thing is, we already know this is prostate cancer. What's the grade of it? Sorry, I think I had a bit of network challenges. I was talking about active surveillance. So the action here is we follow up the patient in intervals, say 6 months to yearly, without instituting any treatment, but we are looking at the PSA. Is the PSA rising, or is it remaining steady? And is it on doing a rectal exam, is it a suspicious prostate? We might also do an ultrasound. So we are just surveying for any progress. To have a low risk, they don't tend to progress rapidly. And so we don't see the need of instituting a treatment, yet the likelihood of progressing is still low, okay? If it's going towards a high risk, okay, based on the biopsy, and it's limited to the prostate, it has not spread, there's a role of doing a surgery. And that surgery is what we call prostatectomy, radical prostatectomy in real sense, because we are removing the prostate in totality. Our intent is not to leave any tissue. of the prostate. There's also a role if it's limited and progressing towards a high risk. There's also a role for what you call hormonal therapy. And hormonal therapy has been shown to help assist in, has been shown to prevent greatly the risk of progressing into prostate that is cancer that is spreading past the prostate to other organs. And the thing is, we are trying to reduce because it's noted that this prostate tends to feed on the male hormones, what we call androgens and testosterone to be particular. And so these drugs, one of the drugs is what we call anti-androgens that act peripherally to reduce the testosterone levels. A good example is bicalutamide, and also what we another drug, another group of drugs is KNH-RH, luteinizing hormone receptor blockers, because they tend to act centrally. So a good example of this drug is goserelin. Okay, so a good example is goserelin. Another, and these are just the examples: leuprolin, goserelin, buserelin, triptolin, histrelin. Commonly in Kenyatta, we tend to use goserelin, and goserelin is given via the subcutaneous route, whereas bicalutamide is usually given orally. And also, there's also a role for radiotherapy in a high risk that is limited to the prostate. And there are two types of radiotherapy. There's an external radiotherapy, which we call external beam radiotherapy. And there's that internal radiotherapy where seeds are inserted into the prostate tissue and they remain there to kill the cancerous cells. Brachytherapy, currently understand it's, we haven't started it yet here at KNH. It's available at Nairobi Hospital. But here we do the external beam radiotherapy. And there's a lot, it has undergone a lot of improvements to reduce risk associated with radiotherapy, because all these treatment modalities have risk associated with them. And then in advanced disease now, there is also a role for chemotherapeutic agents. And a good example is abiraterone. Like I know Johnson & Johnson, our sponsors, have one of the brands that's Zytiga, which is has been shown to help increase the overall survival of our patients. And also another drug that is, the good thing about abiraterone is that it's given orally, so it's very it's a bit hassle-free compared to the other chemotherapeutic agents. These are the class of they're called the taxanes. And commonly, the one that we use in this class is called docetaxel and cabazitaxel. So this is good for advanced and metastatic disease. There's also, so in case of complications, like there's also a risk of a patient going into renal failure because of blockage. We can do what we call a channel transurethral resection of the prostate, where we create a channel so that urine so that a patient can be able to urinate comfortably instead of having a blockage brought about by the cancer. And also in case it's compressing the spine, there are also nerve symptoms, like a patient is not able to walk. And so there's also radiation that can be done at the specific spine where the specific level of the spine where the cancer cells have invaded. And this radiotherapy usually is very promising, because you find that someone was not able to walk, they came in not walking, and after a few cycles, they're able to walk. Another thing to mention is, what's the future? The future is headed towards producing drugs with lesser side effects, and also radiation that is focused towards the prostate, that doesn't affect other organs surrounding the prostate, because there's the rectum, there's also the bladder, and also there's a drug that was approved by FDA at one point, but it's not in the mainstream market, called Sipulsalti. FDA being Food Drug Administration, USA body for regulation of drugs, and for regulation of drugs. but still it's not in the mainstream market. And parts of the country and parts of Europe have not really approved it. But there's trials still to show that these vaccines, it's still, I'd say in most places it's under investigational stages, it hasn't been approved. And it's a vaccine that has been aimed at treating prostate cancer, but does not prevent it. But so that's where we are headed. Yeah, so I think that's it from me, giving an overview. Prostate cancer is something that we can talk and talk and talk and talk and talk. And it's something that we're really passionate about. So unless there are any questions, I'd really, I'm open to them. And thank you for your listening role.
Thank you, Daktari. Thank you for that overview. Dr. Keegan has taken us through this patient, the fact that cancer is with us. Prostate cancer, to be specific, affects the African male more than the others. It also it is associated with some bit of stigma, but we also heard that there are so many prominent persons who have had prostate cancer, but they have gone ahead to achieve what they wanted to achieve in life. So one can also live long and be productive in society with prostate cancer, though it affects mainly the elderly male. So he has also taken us through this patient who has presented to us with some symptoms. Some of them are specific. We can point them towards prostate cancer. Others are non-specific. And we've heard them from the patient who was ahead who was before, Dr. Keegan. He has also talked about, once this patient has presented to us, we have suspected that he could be having prostate cancer. There are some tests that may lead to a diagnosis. Is it a benign problem or a prostate cancer? And what is the risk of the spread of the cancer? What stage is the cancer? And what are the available treatment modalities? He has also looked at some of the medications within these treatment modalities. And I think that brief overview has given us a lot of information about prostate cancer. And we can already see a picture of what the prostate cancer would look like and some of the treatment. And we also heard from the patient some of the effects, the side effects of the treatments that he received. And we can point out what treatment modalities he had and what may be some of the drugs that he actually did receive. So I know we have many questions for Dr. Keegan, but I request that we hold on to those questions until the end, when we shall have a session where we'll be able to ask the questions that we have. So at this juncture, I would like to bring in our third presenter, that is Ronnie Oblemire. Ronnie is an oncology clinical nurse, navigator at the Kenyatta National Hospital Cancer Treatment Center, and he will be talking about some of the survivorship issues in patients who have been diagnosed with prostate cancer and perhaps gone through the treatment for prostate cancer. Welcome, Ronnie. Ronnie, are you there? Hello? Can you hear me?
Allow me to, yes, I can hear you. I
Welcome.
can hear you. Thank you very much. Allow me to share my screen. Can you be able to hear me?
Yes, we can hear you, Ronnie. Go ahead.
Okay, thank you very much. I'm going to talk about cancer survivorship. Daktari has elicited a lot on the various treatment modalities. We had Joshua talk about his treatment journey. So right now, I just want to take you through the various survivorship aspects so that we are able really to understand and orient ourselves to what cancer survivorship entails. So really my area of concern or interest is to enable us to really appreciate what are the various aspects cancer prostate survivors require and the kind of support they need from healthcare workers. So in terms of epidemiology of prostate cancer, we know that in Kenya, prostate cancer is one of the leading cancers. And globally, you find, according to the global cancer statistics, you have almost 1.2 million cancer cases being reported worldwide. And worldwide, it is the second leading cancer that is noted in men. And usually in Africa, an African setting, it is more related with high mortalities because of our limited resources. And in terms of way we screen our patients, most of our patients are, the cancer is usually detected in very late stages. We've had various studies that have been done. There have been studies by Magoha that really showed that most of the cases that were being managed in our clinics were stage 3 and stage 4 disease. So in our Kenyan context, according to KNH-UoN, prostate cancer is the most common cancer that it has a prevalence of 17 per 100,000 men. And because of the challenges that we have, we've talked about a high poverty index, and high poverty index has an impact on the way we manage our patients, because you might refer a patient, but they don't go to the next service point because they have inadequate resources. And sometimes there is lack of awareness where patients who have been diagnosed opt to seek other alternative treatments, unlike our conventional treatments that have a scientific backing. So we have had a challenge, and most of our medical personnel are found in major cities. And in the rural settings, we have inadequacy in terms of diagnostic facility. And not even, apart from the diagnostic facilities, we have issues with human resource. Diagnostic facilities are some of the facilities that Daktari has elicited. We talked about the PSMS scans, the radium scans, and you find that some of even these treatments you need to come to to the cities like Nairobi so that you can be able to get them. And even now we have treatments that have come up, the cyber knife, robotic surgeries that one maybe needs to seek abroad because of our limited capacity. So cancer incident and mortality rates is still alarming, with 850 deaths being recorded in those who have been diagnosed. But we know that early diagnosis really has a greater impact on the prognosis. So the earlier the detection, the better the outcomes. So that has been, I've already talked about KEMRI, and also in our setting. We find that the cancer registry indicates that most of our cases are in advanced setting, and usually the treatment is usually palliative intent. So who is a cancer survivor? And what is survivorship? So from the NCCN guidelines that we rely on, survivorship has been stretched a bit further, because previously most of us have been fixated to think that survivorship is usually when one has gone through the treatment and has completed the treatment. But NCCN has pulled it back further to really incorporate when a patient starts the treatment at the time of diagnosis, one is seen as a survivor already, because one has to really transform his mind to think beyond the treatment and the cure. So he's going to overcome the disease. So from starting at the diagnosis and during and right in the treatment phase and through the rest of his life. So that is what survivorship entails. Yeah. So most of our thinking has been on through the balance of their life when they have already been treated. So survivorship aspects entail to support patient and promote better outcomes post the treatment. So looking at the various standards that have been set aside by NCCN, survivorship aspects include the prevention of new and recurrent cancers. You know, the various treatments that we give can likely expose you to secondary malignancies, especially the likes of radiotherapy and chemotherapy, on how they work on the DNA. So you find that because of such treatments, you might be exposed to secondary malignancies. So there is need for us to really ensure that we are able to prevent new and recurrent tumors, and also to be able also to ensure that we prevent late side effects that come with the treatment. And I'll talk more on the late effects that come because of the treatment. We have to do routine testing and surveillance, because the earlier the detection of recurrences, the better we are likely to really manage. Then you find that there is need for us to assess the late side effects that come. And for us as healthcare providers, we need to coordinate the care between the caregivers, the patient, and us. And also we need to plan the ongoing survivorship programs so that we are able to support patients in their survivorship phase. So in terms of prevention of cancer, I've talked about this, because of the way we administer the standard treatments. We have surgery, we have chemotherapy, we have radiotherapy, and we have hormonal treatment. And of course, the new treatments, immunotherapy. So you find these treatments, how they work on the cancer. You find that cancer, how it occurs is because there are mutations within the DNA. And you find in terms of the proofreading, so that the strand is okay. We have issues there. We have issues with the strand, how we break the length of the strand in terms of the DNA. You find that it is altered. So you find what happens is the treatments, like in this case, radiotherapy, will tend to, because of the fragility of the DNA strand, you find that we give radiotherapy so that the strand is able to be broken, so that the chain of new strands that are produced, the replication process is altered. So you find like in that case, it likely might affect the cell, how it is able to produce, and the new mutations can come up. So our role of as healthcare workers is to prevent new cancers. And how do you prevent new cancers? You find that there is need for us to encourage the patients to avoid carcinogens. And carcinogens, we are talking about alcohol, tobacco intake. We are also able to detect early the secondary cancers and manage accordingly, so that there is a better prognosis. So the issue of quality of life for cancer survivors is an issue of concern. We might give the treatment, but the treatment, we know, like most of the treatments have a potential to cause side effects. So there is need for us to holistically look at how the patient is and look at the quality of life, so that patients are able to live a better and fulfilling life. So we have to holistically manage them, look at the physical well-being, the functional abilities. Yeah. Treatments like chemotherapy might affect your physical well-being in terms of fatigue. You find that because of how the treatment works, you might be exposed to fatigue. Even the hormonal treatments, what we're calling androgen preventing therapy, Dr. has talked about, might affect your overall muscle strength and well-being. You have fertility issues, and you find that these are issues that we have to really focus on so that patients are able to have a functional life and also be able to go through the treatment. And in terms of the social well-being, we have to look at, assess our patients, see how are the support structures, because patients who have weak social support network, they don't complete their treatment and don't adhere to their treatment and even their follow-ups. So we need to see mechanisms on how we are able to enjoin the significant others in their care. Even when a patient is coming to be seen, you might maybe need to get consent, because most of our patients, those who have been diagnosed, spend 40 years and above. So sometimes you might need to have like a caregiver there, so that they're able also to support the patient. Yeah. So also the psychological well-being, you have to look at the issues of anxiety, the issues of depression, the issues of fear of recurrence, especially when they're in the survivorship phase. We have also issues with the memory and attention. Yeah. So, and even how we break their bad news to patients. There is need for us to improve on our communication skills. And then the spiritual well-being. How does the patient interpret their disease in terms of their spiritual well-being? Are they seeing it as a witchcraft or a curse? Yeah. So we must restore the hope of our patients, so that we are able to build their resilience as they go through their treatment and also in their survivorship phase post their treatment. So factors that affect the emotional well-being, there are so many factors that might affect the emotional well-being of prostate cancer survivors. And we are talking about the physical factors. Physical factors, the side effects of the treatment. And even you find also the social factors. We have the issues of stigmatization. Yeah. Most of our men don't talk about cancer, and they have what we call social avoidance behavior, that they don't want to seek support. Yeah. So we have to see how best we can support them through. And then also we have the societal issues. So psychological factors, we have to inculcate positive emotions. We have also to support the individual, because some of them keep on questioning themselves and blaming themselves, because they might think that the disease came because of their past mistakes, which is not actually true. Yeah. The socio-economic factors. Sometimes, of course, there are standards of care that we have, maybe to do a parametric MRI, we have to do a whole spine MRI for maybe a patient who has advanced disease. We have to do various investigations. But even as we do that, we have also to look into the financial stability and maybe utilize the support structures that are existing within the hospital, the social worker department, the chaplaincy, so that as they go through the treatment, they are able to be supported. We have cultural norms and cultural practices and spiritual practices that affect the emotional well-being of patients. And through the experiences that you have had that patients go through various hardships. And our first presenter, who's our cancer survivor, elicited that, the issues of stigmatization and the abandonment by family and friends. We have also the negative outcomes that come with the treatment, the sexual life, which is usually affected. Yeah. Emotions that come because of a change of body image, the alteration in body image might affect the self-esteem. Yeah. So we need to give information so that that information will enhance the coping mechanisms of our patients. So when you look at the effects of the treatment on sleep and fatigue, realize that cancer treatments might affect sleep and fatigue. Surgery, because of any blood loss, there might be an issue of fatigue coming in. Of course, the radiation and chemo, we find also that might affect the quality of life, because it will reduce the compliance with the treatment and result in poor prognosis. So the cancer-related fatigue can be pathological in nature. Yeah, you note that most of you looking at the physiology of pathophysiology of cancer, you find that there is usually a lot of muscle wasting, what we call cancer cachexia. So that might present also with fatigue. And you look at also the demographic factors. Most of the patients most of our cases are age, yeah, and the environment under which they live. You might maybe say balanced diet, but they don't have the means to achieve that. So you find also that can affect. So fatigue, you must assess it holistically and find mechanisms to manage that. And how do you manage fatigue? Fatigue can be, you need to treat it, can be because of the medical issues, but also can be because of depression that comes because of the stress, the treatments, and the disease and the environment which one lives. So you have to also look into that because that affects most of our cancer survivors. So you might prescribe physical activity because physical activity, we know that exercise tend to improve our mood because of the hormones, the good hormones that are secreted.
Hello, Ronnie, are you there? Hello? Do we still have Ronnie?
Sorry, I must have lost my.
This meeting is being recorded.
Yes. So I'll try and be brief, but we are talking about how do you manage cancer fatigue. We are talking about exercise, the cognitive behavioral therapies. We have to engage the psychologists and maintain a balanced diet. We're also talking about osteoporosis. Osteoporosis comes because of the androgen deprivating therapy. And androgen deprivating therapy, there is a way that the reduction in testosterone levels, we note that tends to affect our bone mineralization. There is a role of testosterone and bone health. So we find those who receive androgen deprivation therapy, they are a high risk of osteoporosis. And even patients who have a Gleason score of 8 and above, we have to evaluate them for bone metastases. and also high level of PSA above 100, you need also to look at their bone health, because they are likely to have, and also those who are presenting with the issues of bone pains. You need to also to look at that, so that we are also able to manage their cancer, because most of the time prostate cancer tends to affect the spines, the sacral bones. So how do you manage osteoporosis? Recommend balanced diet, encourage exercise, healthy lifestyle. We know alcohol tends to affect the way we absorb our nutrients. So you need to encourage a healthy lifestyle. Yeah? Avoid alcohol. That is very, very important. We need to do what we call a bone mineral density test. We have talked about the DEXA test, because it does help you in terms of determining whether there is osteoporosis. And then we have also the medication. We know about the biphosphonates to strengthen the bones. Zyphos is usually most of the time the one we use. There is also new drugs, the nosumab, which has been shown also to be very effective and is also FDA approved. So it is important to do that. For hot flashes, it can be very distressful, and it is because of the reduction in the sex hormones, which affects our thermoregulatory centers in the brain. So it is important to manage the hot flashes, and we can manage through psychotherapy, because it's the recommended way. And also the challenge with the medical treatment with regards to hot flashes, you find that it also has, these treatments tend to have more side effects. So we need to recommend psychotherapy. And then also the triggers of hot flashes, you have to avoid alcohol. Yeah. So cancer treatment tends also to affect the cardiovascular system. And how does the cardiovascular system get affected? You find that you note that there is an issue with the way the testosterone tends to, because when you deprive the testosterone, you increase the low density lipoprotein in the circulation. And also you find there is issues of insulin resistance that tends to happen. So there is need for you to look at how that the issues with the heart, ensure that patients are able to be monitored their blood sugar levels. They manage a balanced diet. The issues of weight, yeah, you now need to exercise, because exercise is very, very important. Recommend that for our patients. And most of them have also other comorbidities. Yeah. Then we have a cognitive dysfunction, where we are talking about impairment in reasoning, memory, problem solving, attention. And usually chemotherapy has been associated with what we call chemo brain. And chemo brain, we are talking about where there is the memory tends to be altered. There are memory issues, because most of them have issues with the attention span is reduced. We also finding that most of them are not able to follow instructions. There is issues with confusion. We are also issues with the difficulty in associating. So we need to encourage mechanisms, and some of them have elicited. We are talking about relaxation therapies, avoid the triggers. I'll also talk about sexuality, which is a major issue because of our time. Sexuality is poorly assessed. Sex and the sex life, because most of the studies that have been done on prostate cancer, we find that the issues of sex life and sexuality are poorly assessed by the medical workers. Sexuality is a process of where one is able to express himself in terms of sexual pleasure and belonging and acceptance. So we express our sexuality in terms of our thoughts, desires, and how we relate with one another. So the treatments will affect sexuality, and because of the low testosterone levels and because of the treatment, we are talking about surgery. Nowadays, with the treatments, we are talking about nerve sparing surgeries that improve sexuality and sex life. But because of the illnesses, other comorbidities like diabetes and hypertension, they affect the sexual function, the mental status of our patients. Most of them are depressed, and the treatments will affect their self-image, because most of them will, when the treatments come and the individual is not able to maintain and sustain an erection, they get into a depressive mood. And so what happens is you find that that affects their manhood. So you have to talk about issues of sexuality and assess the sexual function, because most of our patients, when this occurs and you've not talked about the treatment side effects that will occur, most of them stop taking and adhering to their treatment. So assess sexual function, and the symptoms are some of these: a low sexual desire, trouble having an orgasm, and getting aroused. Barriers to attainment of sexual health: most of our patients are in denial. And when you talk about it, they say, no, we stopped, I don't think about it. And they feel maybe it's not the right time. But sometimes it's always good to provide an opportunity, because when you provide that opportunity, they start expressing themselves and they are able now to be supported, so that they don't take other agents that might have harmed them in the process. So encourage open lines of communication with the partner, make appropriate referrals to the right people, encourage healthy living, and alcohol avoidance. Support the caregivers. Caregivers are usually stressed also in the process, because they have what we call primary strain because of the physical demands that come with the treatment, and they have also what we call secondary strain, because the disease is likely to impact negatively on other aspects of their life, like employment and finances. So they need to be supported. So in conclusion, I want to recommend that we need a multidisciplinary approach to be able to holistically support our patients. We need to actively engage them in support groups, reinforce open lines of communication between us and the patients. We need to work with them and hold them and be in their corner, so that as they go through the treatment and as they finish their treatment, they are able to know that there is a way that they can be supported, that we care for them, and we are there to support them through their journey. And also we have to reinforce positive aspects like exercise, diet, and avoidance of risks that come with the unhealthy lifestyle. So thank you very much.
Sorry, I was logged out. I'm back now. Thank you very much, Ronnie, for that elaborate presentation. So survivorship is, maybe we should think about survivorship at diagnosis and support the patient through treatment. And think about having psychosocial support at every stage of these patients, and involve the patient as well as the significant others at all levels of their care. Knowing that this patient is the same man at every stage, the same man that came to us pre-diagnosis. And as we go through treatment, we having at the back of our mind the changes that may come along. Maybe it will be important to prepare the patient well so that he's able to go through those stages and the changes that may come around. And then we should know that psychosocial support for this patient is as important as the treatment that we want to give them. And at the end, a multidisciplinary team approach will be important. Take the patient, navigate the patient through all the care pathways and give coordinated care. And all these will lead us ultimately to an effective treatment, as well as a good outcome for the treatment that we intend to give to these patients. And maybe then we give them some quality in their life. Thank you very much. I know that we have so many questions that we would want to ask. I have seen a number of questions in the Q&A chat boxes. Most of them are to Dr. Keegan. I am sure that, Doctor, you are able to access this question and answer chat boxes. I will also give 2 or 3 participants to ask questions. Please raise your hand. If you're able to, I will give you a chance to ask questions. But before we get there, Dr. Keegan, please, you can start with some of the responses. If okay, you're able to, yes, you're able to access the QA chat.
Yeah, certainly. Yeah, I can, yes.
Yeah, please do.
All right, see there are a number of questions directed to me. Hopefully, I hope to answer to your satisfaction. I think there's a question on risk factors of prostate cancer, in particular zinc. I want to say, and I'll quote more of evidence-based medicine. I've come across 2 studies that talk about zinc that evaluated zinc with respect to whether was it a risk or a protective factor. And there's one American study where they were following up 46,000, about 50,000 men, and they followed them up for more than 10 years. And they found that those who would be labeled as users of zinc, these were people who use the value we give is 100 mgs in a day. So they found that those who are using, and the non-users are those, of course, who are using less than that value. So so these 2 arms, the users and the non-users, they're able to find that those who are using zinc had a 2% more risk of developing prostate cancer. So this should be taken with a pinch of salt, yeah, because it's not, when we look at, like in science, when you look at evidence, there's what we call expert opinion, case reports, and those are usually low-level evidence. But high-level evidence is like, say, Kenya has done a study of zinc, Tanzania has a study of zinc, India, Japan, America, and they tend to tally, finding similar things, that users have a higher % risk compared to non-users. Then that one now you take it now with utmost legibility. So to answer your question on zinc, there are only 2 major studies, and they report that there's a 2% risk of developing prostate cancer if you're a high zinc user. That's what we have currently. Second question is about having multiple sexual episodes as a protective factor to, I think, is yielding towards BP, but I also talk about prostate cancer. It's just a myth, and this is something I want to demystify. So it does not have any benefit of someone, whether benefit or protection against prostate cancer or benign prostatic enlargement. So that's a myth. It's very common, even when, let's say, we go talk to, for example, we're invited by churches to talk to men in the men's group, and this is a question that usually comes up a lot. So there's a lot of myths regarding multiple sex as a protective factor to BP and prostate cancer. And the thought there is the number of times someone ejaculates helps to shrink the prostate. So that's not true. Yeah, that's just a myth. Number 3 is regarding painful ejaculation. So painful ejaculation can be, prostate cancer can be a cause, okay? But really, it's not really the common cause. The common is an infection of the prostate, what we call prostatitis. Another thing is a patient who has undergone a prostate procedure, for example, a biopsy. Painful ejaculation can be a side effect of post-operative. There are also infections that can cause that, like commonly Trichomonas vaginalis is known to cause that. Radiation to the prostate, and also antidepressant drugs. A good example is a class of drugs called the tricyclic antidepressants. So painful ejaculation has many, what we think of is prostatitis. Another good question is on screening of prostate cancer. I know there's an oncology working group in Kenya coming up with a screening guidelines in the near future. But we'd have to use what we have in the Americans and the Europeans agree that screening should start at 50 years. And number of studies have shown this, and like I quoted the mortuary study where 30% of those who are 50 years in their 50s had prostate cancer. So I want to talk about, let me just dwell in a bit on screening. So when we do, there's talk of doing mass screening, and the danger of doing mass screening is that you overdiagnose prostate cancer, because there are those ones with a low risk and you might get them from overscreening. And yet this prostate cancer is not bothering them. They are being able to go on with their business, whether they're going on, whatever they do daily, be it farming, be it going to an office, border, whichever, but they're just running their own, continuing their own life. So you find that we tend also to overdiagnose and causing unnecessary anxiety. Yet these patients, they just have it, yes, but it's not bothering them. Yeah, so we are leaning more towards opportunistic screening, where someone with symptoms, and then you go ahead with the whole protocol. Another question is, so I've answered 50 years, but the caveat is if there's a strong family history, yeah, then screening should start early, and the proposed age is 45. Yeah. Role of prophylactic prostatectomy, that's a very good question, because this is something that we also get a lot in the barazas. So currently, prostatectomy, whenever you do an intervention in medicine, be it administering a drug or be it surgery, you have to discuss pros and cons, yeah? And now it's up to the patient to consent to the procedure. Prostatectomy in itself has some cons or risks that can occur. Not necessarily that it must occur, otherwise we wouldn't be doing that procedure. Yeah? So we say that prostatectomy, in this respect to cancer, we do what we call a radical prostatectomy, where we remove all the prostate. Yeah. So prostatectomy has effects because it can lead to bleeding. It can lead to infections. Yeah, the wound can be infected because you're creating a wound by doing surgery. Yeah, although it's a controlled wound. there's also risk of, because where the prostate is, there's also the sphincters, like the brakes mkojo. Yeah. If the brakes are affected during surgery, there's risk of incontinence. Okay. Yeah. And there's also risk of erectile dysfunction, because the nerves that go towards supplying the penis, the male reproductive organ, they go lateral to the prostate. So
Sorry,
there's a risk
Dr.
of,
Keegan.
yes.
Sorry, I have to cut short our
Okay, no
session.
problem.
Sorry,
Okay,
we have to close before we are.
Okay, there are a number of questions. Sir, no problem.
Yes,
Thank you.
Thank you very much. I am sorry to the participants. We may not be able to finish up because of time. So I can see that this is a very interesting topic, and there's a lot that we would like to get answers from Dr. Keegan and the others, but unfortunately we may not be able to do that now. We can also get in touch with Dr. Keegan. If you have a really pressing question, you can talk to him. After this meeting, he's available at the urology clinic, especially urology department in KNH. But as of now, I wish to thank everyone for your participation in this session, and a few other concerns that I think the host will address. 2 concerns about the CPD points and the recorded version of the session. The host will address. Otherwise, from my part and the other panelists, we thank you very much for your participation, and you're welcome next time. Thank you, and I hand this over to Nelson at KNH Research Department to continue with the rest. Thank you very much. Nelson. Nelson, you're off. Okay. Thank you, everyone.
Hello, Anastasia, can you hear me now?
I will see how I will go about.
Nelson from KNH, are you there?
Yes, I am here. I had a problem with my mic, but I'm here now.
Yes, there are 2 issues you have to address before you close. That is about the CPD points. And especially the ones that had not been accorded, and whether you are able to avail the recorded version of this session for today. There are some members who needed to have, they have raised this on their question and answer session.
Okay. So well, let me first address the CPDs. The CPDs will be sent within 2 weeks for this particular session. This is because we normally have large volumes of attendees, and also collaborating with the various bodies so that we can get the CPDs and then send them to the participants. We will be able to send for KMPDB, we'll send them to your emails. PPB, you are required to subscribe to the session on the portal so that you can receive your points. Nursing school, nursing council, the portal we were informed was down for a bit, so we'll wait for the nursing council to advise, and then when they are back online, we'll be able to generate the CPDs and then send them to you as well. For the recording of this session, this session will be uploaded to our website, and once it has been uploaded to our website, we will notify you of the same, and then you'll just navigate. Yes, you'll just navigate to KNH-UoN webinars or rather you go to knh.or.ke and navigate to the webinar tab, and there you'll be able to find all of our recorded sessions. So not only for this particular event today, all the sessions we've been able to hold within the year as well. So I think Anastasia, I've covered the questions that were asked. If I may add, tomorrow we are having a session on World AIDS Day, and we'll be commemorating the World AIDS Day here on the Zoom platform. The theme will be to equalize, and the program, or rather the topics to be discussed, are as displayed on your screens. All right, thank you. Anastasia, are you there, still there?
Yes, I am here. I think we had finished.
All
Thank
right.
you very much. Yes, we can close.
Okay. So thank you so much for your input today, and also thank you for our participants for joining us. See you tomorrow, and goodbye.
Goodbye.